You're listening to Medscape's In Discussion series on respiratory syncytial virus in adults, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Forrest Arnold. Dr. Arnold is the chief of the University of Louisville Division of Infectious Diseases and director of the Center of Excellence for Research in Infectious Diseases. He also acts as the co-editor-in-chief for the Journal of Respiratory Infections and program director for the Clinical Fellowship in Infectious Diseases. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Forrest Arnold, and welcome to Medscape's In Discussion series on RSV in adults. Today we'll be discussing RSV in older adults. Dr. Morton is currently an associate professor at the University of Louisville School of Medicine, specializing in geriatric medicine, home care, and long-term care. Welcome to In Discussion.
Thank you, Dr. Arnold. I'm happy to be here.
Dr. Morton, we used to call this population elderly, but the new term is older adults. And for those greater than 85, the phrase old is still used. I don't think they had any buy-in for that term. Regardless, we will use older adults for this episode. I would like to start with a case of somebody typical that you might see in your practice. What kind of patient do you see?
So actually recently I have seen a patient who had RSV. She's a 90-year-old female living in the nursing home setting. And she had diagnosis of the typical older adult things that I see in the nursing home, including dementia, hypertension, and diabetes. A lot of these patients that I see on a daily basis are frail, require assistance with their ADLs, activities of daily living, and that is why they're in the facility. She was living in the long-term care facility and doing relatively well. She did develop some vague symptoms, including cough and weakness, but wasn't able to report the history to us as she does have dementia. But one day, the nurses were checking on her and found that her oxygen saturations had dropped into the 80s, which was a new thing for her. At that time, she was sent out to the emergency room for evaluation.
Does your role extend to the care of the patient in the hospital?
No, it does not. So as a nursing home attending physician, I take care of the patients while they're in the facility. But when they transition to the hospital, it goes on to the emergency room physicians and then also to the hospitalist team there.
Okay. So tell us about the course in the hospital.
So in the ER, she had a CT scan of her chest, and the findings were consistent with bronchitis. They also did a respiratory panel on which she tested positive for RSV. Because she was frail, older, and had the lower oxygen saturation, she was admitted to the hospital and treated there with supportive care. She was placed on oxygen but did not require oxygen for very long, was given IV fluids, and remained in the hospital about 2 days.
So she was not in the ICU?
She was not in the ICU. She was able to remain on the floor, but they were able to monitor her there and make sure that she did not have any decompensation while she was there.
Okay, and her treatment?
The treatment that they gave was really IV fluids and the oxygen. They were monitoring her oxygen saturations closely, but she really didn't need any additional therapy at that time.
Okay, it sounds like she did well if she only spent 2 days in the hospital, but what was her ultimate outcome?
Well, so after the 2 days in the hospital, she transferred back to the nursing facility. And amazingly enough, in our frail older adults, it is very easy for them to have a decline from any kind of acute event. Even a 2-day stay in the hospital can precipitate a decline. She did return to the facility, was able to work with physical therapy and occupational therapy to try to regain her strength. However, what we have seen with her is that she's still living, but she's had a cognitive decline. So because of her dementia, when she had this acute event and went to the hospital and came back, her cognitive function has not returned to the previous pre-infection baseline.
Okay, so she got supportive care, and our listeners may be wondering about ribavirin and its use in a case like this, but ribavirin is only FDA approved for hepatitis C, and it is associated with certain side effects that would not be good for an older adult, such as pancytopenia, anemia, neutropenia, thrombocytopenia, and it can exacerbate certain comorbidities like diabetes, coronary artery disease, arrhythmias, thyroid control, whether hypo or hyperthyroidism, and colitis. So the risk of using this medicine would be much greater than the benefit, and makes sense that you would not use it. I've only used it off-label in bone marrow transplants who have pancytopenia, but again, that risk benefit is difficult because I'm already dealing with people who have pancytopenia. So supportive care is very important in a case like this. What is the course of RSV in patients who do not get admitted and they stay in the long-term care facility?
So those that don't get admitted, so we'll see sometimes the patient will have symptoms. We will isolate them usually for about 48 to 72 hours and monitor their vital signs closely to make sure they're not developing any oxygen saturations, and listen to their breath sounds to make sure they're not developing pneumonia. Most of the patients that live in a long-term care facility have some level of immunocompromise and immunosuppression just by virtue of their age. So in our older adults, we see the process of immunosenescence, so the aging of the immune system, which makes them at greater risk of having more significant complications with any kind of infection. And those who are older and frail and have other underlying lung problems, whether it's asthma or COPD, pulmonary hypertension, or if they have underlying coronary artery disease, they're at greater risk of developing severe infection with RSV, including pneumonia. So we have to monitor them closely, give them fluids if needed. We can do IV fluids in the nursing facilities. We try to avoid doing invasive things, as any tubes and lines can contribute to delirium in that patient population. So we'll try to encourage oral intake as well.
Okay. And then in those long-term facilities, what tests are available?
Generally, in the long-term care facilities, what's readily available, especially since COVID, we have flu and COVID swabs that are readily available. We have not been routinely checking for RSV and doing the broad respiratory panels in the nursing facilities. They are a little bit harder to obtain, and the cost is a barrier to getting those in the facilities.
Right. And I'm more familiar with the hospital, and even there we have two panels, one that's long that has 10 or 12 viruses on it, and the other one is a triple test for influenza and COVID-19, as you mentioned, as well as RSV. But it's not this test that's typically in the facilities where you are. It's a dual test of just influenza and COVID-19. So that seems like an area where there's a need, because it's difficult to treat somebody or isolate for RSV when you don't even know that they have it.
Absolutely. I would guess that over the years, there's been a lot of hidden RSV that's gone undiagnosed in long-term care facilities. With COVID-19, there's been a greater emphasis, obviously, on testing and being more aware and aggressive with trying to determine what is going on with any kind of infection in that setting. COVID-19 has really highlighted that need to try to do control processes, whether it's isolation, whether it's being more proactive with masking, because prior to COVID-19, as we all know, we were not routinely wearing masks in the long-term care facility.
So to summarize to this point, it sounds like the RSV in the older adult has a course similar to influenza, and there is no treatment available except for supportive care at this time. So it would benefit to identify early, because the sooner you start supportive care, the better the outcomes, and you could also isolate sooner. We're familiar with outbreaks of influenza and COVID-19 in nursing homes, and RSV would likely be just as severe as those other two. So I want to change subjects just for a second. You are on a task force. Can you tell us about that?
Yes. So at the beginning of COVID in 2020, I was appointed to the Kentucky Governor's Long-Term Care Advisory Task Force, which is for the Kentucky Cabinet for Health and Family Services. And it was put together of leaders from various fields, including the infection prevention folks in the state, as well as epidemiologists, the ombudsman with the state, representatives from AARP and the Alzheimer's Association, as well as state officials and other medical directors, to really focus on providing guidance for long-term care facilities, as well as other congregate living settings, including assisted living, personal care facilities, and some group homes as well. We also work to give advice to the adult day centers. So the task force came together trying to provide guidance as we experience the rapidly changing environment to try to help providers, those providing care for those residents living in those facilities, some idea of what they could do in that ever-changing landscape, how we could best work together to provide care for that population who was very frail. And at the time that this was started, there really wasn't a lot that we could do for that population.
And this started for COVID-19, but it kind of changed to incorporate RSV, correct?
It has. The great thing is that we still meet, though we don't meet as frequently as we did early in the pandemic, but we are meeting monthly and discussing other topics that are pertinent to this population, including RSV. So during this season, we talked early on in the fall about COVID-19, flu, and RSV, and what we can do to help provide these facilities with some guidance, because there really is not a lot of guidance out there about what to do with RSV in long-term care facilities.
Now, when we look nationally, because your task force is at the state level, what guidance is there about RSV for nursing homes and long-term care facilities?
There really is not a lot of guidance out there for long-term care facilities and RSV on the national level. Before this podcast, I was looking, and the CDC does have some general guidance about RSV in older adults. However, it is not specific to the long-term care setting. There are some states across the country that health departments have provided some very general and broad guidance regarding RSV in long-term care facilities. Most of the guidance for long-term care facilities is about isolating patients who have RSV, usually for 48 to 72 hours, depending on symptom course. Also to encourage those patients to wear masks, which can be challenging at times given the patient population that we serve, as well as doing that supportive care that we've been talking about, whether it's IV fluids, pushing fluids, and doing good respiratory therapy like flutter valves and incentive spirometry to try to promote the best oxygen and respiratory status we can.
Okay, so when I think about recommendations for influenza or COVID-19, it seems like there's much more literature and certainly CDC pages to read than I could get through. But for RSV, it's a limited amount. And so what guidance is needed with RSV specifically, and what topics would you like guidance to elaborate on?
Well, I think especially in this setting with congregate living, whenever there's a question, a patient who tests positive for RSV, the infection prevention nurse, which all facilities will have because of the regulations, will come to me and say, hey, Dr. Morton, as medical director, what should we do with this patient regarding activities? What are they able to do? Are they able to go out to the dining room? Are they able to go to physical and occupational therapy gym? Or do they have to do all of that in their room? So that very specific guidance about what that patient is able to do regarding activities and how they're able to interact with the staff and other residents is very important.
It is. And probably most people can relate during COVID-19 because it seemed like there was, for lack of knowledge, there was a lot of, for safety, they kept patients in their rooms. And so my own father-in-law was in a nursing home. He needed physical therapy, wasn't getting it until finally somebody eventually came in. But we all felt like his rehab took much longer than it would have otherwise. And he didn't even have COVID-19. So somebody with RSV, if you had guidance on how to get those people out into their activities and get the healthcare workers to them, then their rehab would be faster. And with an older adult, the more days they have not getting out of bed, not even getting to the bedside commode, the harder it is once you get up. Do you find that?
Very true. We always say if you don't move it, you're going to lose it. So it's very important to get people up early and mobile. And during COVID, we really saw the significant impact of isolation on patients, whether they were long-term patients in a nursing facility or there for rehab. That social isolation really was detrimental to their overall physical health as well as their psychological health as well. And therefore, we recognize that need now because of COVID, of how important it is to figure out how we can quickly get people, as soon as it's safe, out into the community, out where they can interact and where they can get the necessary services, including physical therapy, occupational therapy, speech therapy, which is much more easily done in the therapy gyms and with the machines and equipment that are available there than in their rooms.
Okay. Well, you're out in these long-term care facilities and you don't have a lot of guidelines, but you have to do something. And so what do you end up doing and recommending and advising the people there in their care of the older adults?
So I think that I give my staff and my infection prevention nurses a lot of reassurance. There is, I think, because RSV is not talked about in our older adult population, I think there is a little more anxiety about what that might mean for our older adults. People do know about RSV in children, and they hear about it and they're familiar with that, but they don't know how that translates into that older patient population. So that can actually cause a little more anxiety because it's the fear of the unknown. And I think a lot of our healthcare workers do have some kind of residual anxiety and trauma related to the early stages of the COVID-19 pandemic about not knowing what to do with the unknown. And so I think anything we could do to help with that and bring out knowledge and awareness about RSV will address those issues. With my infection prevention nurses, I talk to them for RSV about hand hygiene, the things that we know that we should be doing, but remembering to remind the staff the importance of hand hygiene, reminding patients and staff about coughing etiquette. And though these are small things, they're very important. And we learned that as well with COVID. We also talk about the environmental services staff and needing to really clean high contact surfaces to make sure that we are minimizing any kind of spread that way. Again, we try to encourage the patients who get sick to wear a mask. And so hopefully we have a patient who is cognitively aware enough and can tolerate a mask, which will allow them to hopefully get the care they need more quickly than having to stay in their room because they can't remember to keep a mask on.
These basic things are so important, like hand hygiene. And then it's also important to be able to understand how to deal with this. COVID-19 has certainly filled in some of the gaps that we can apply to RSV, but not everything. And some more specific guidance would certainly help. So finally, how does RSV relate to advanced care planning?
RSV and any kind of acute event, whether it's infection, whether it's a fall, or a change in mental status, is a great reminder and an opportunity for us to talk about advanced care planning and goals of care. Whenever we do anything in medicine, we want to make sure that we're taking the guidelines and the guidance that is available and focusing it on the patient that is sitting in front of us and really looking at that in light of the patient's preferences and goals of care. In the nursing facilities, it's always important to talk about code status regarding full code versus do not resuscitate. But we also want to talk about things like do not hospitalize orders, which are available in facilities, and whether going to the hospital is consistent with a patient's wishes or if they'd rather try to manage things in the facility and not undergo that stress or trauma of going out to the hospital. So it's always really important to take any kind of infection, change in the patient's status to take a pause as a physician and review those with the patient or their healthcare surrogate and family as needed. It can be challenging at times to have those conversations, but our job as a healthcare team is to respect the patient's wishes and to help them make informed decisions. And so this is a great opportunity to, again, circle back to that very important topic.
What I've heard in the second half of the episode is that more national guidance for RSV in older adults is needed. And on the state level, task forces that may have been developed for COVID-19, those could be expanded or at the very least recycled for RSV that has rising awareness of morbidity and mortality in older adults. Today we've heard from Dr. Morton discussing RSV in older adults. Thank you so much for joining us. This is Dr. Forrest Arnold for In Discussion.
Thanks for listening to Medscape's In Discussion Respiratory Syncytial Virus in Adults podcast series with our host, Dr. Forrest Arnold. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on respiratory syncytial virus in adults.